Hello, my name's Lynne Mann. I'm a Service Improvement Manager with the Scottish Government and a physiotherapist.
Hello, I am Dr. Simon Watkin. I'm a consultant physician at the Borders General Hospital, Melrose, Scotland. We are introducing this instructional video on behalf of the Scottish Government Quality and Efficiency Support Team. We have also produced a helpful booklet to accompany the video and which would be helpful to have available when watching the video.
The video assists with the preparation for the Day of Care survey, which provides a snapshot of bed utilisation in hospitals. It is carried out in a single day, usually between 8 and 10 AM. All inpatients are surveyed at the same time.
If you're doing the survey for the first time, rather than as part of a regular programme, you will need to prepare several months in advance to give sufficient notice to the reviewers. We recommend that a small team takes responsibility for the organisation of the survey in advance. The accompanying booklet provides further information, and we are happy to provide additional assistance and advice as needed.
The Day of Care survey was developed by a national expert group and has been used regularly. By 2016, over 8,500 acute hospital inpatients have now been surveyed, mainly in Scotland but also in England and Australia.
The survey methods and results for the first 3,500 patients have been published in a peer-reviewed journal.
We're going to describe the survey to be used for acute hospitals. A version for community hospitals is also available, for which the clinical criteria are different, but the methods are the same.
So, as well as looking at the video, you'll need a copy of this booklet, and a few hard copies will have been provided in advance to your organisation. But the booklet's also available online for you to read and download or print as needed. You're definitely going to need to print some copies of this because the data sheets are actually in the booklet and can be photocopied directly and used. Well in advance of the survey date, the organiser should recruit enough volunteers to provide 2 reviewers per ward. Surveying 30 beds will take approximately 45 minutes. At least 1 reviewer in each pair should have a clinical background. All wards should be included except paediatrics, obstetrics, intensive care and mental health if present. Some local discussion will be needed for areas such as those with rehabilitation beds or high dependency units.
Patients who have been in the emergency department for over 4 hours and patients in unfunded, overcapacity or surge beds should also be included. This may lead to occupancy rates over 100%, but provides a true snapshot of actual activity on the day.
The review teams should be provided with the survey details in advance and asked to read the survey booklet. We recommend a short briefing session the evening before the survey to allow for any questions, to confirm ward allocation and to cover for any unexpected reviewer absences. Wards should be alerted to the date and time of the survey and asked to assist the reviewers if required.
Reviewers visit wards and use the charts provided to check each patient in turn against the survey criteria and to examine reasons for delays in patient flow. We recommend using the clinical notes to do this. It should not be necessary to interview patients or go to the bedside. The senior nurse on duty or the ward doctor should be asked to assist with patient information if this is not readily available in the clinical notes.
The first question to answer is whether or not individual patients meet any of the clinical criteria listed in Chart 1. There are 28 criteria which define the need for acute hospital care, divided into 2 groups for convenience. The first group relates to diagnosis and vital signs, and the other group relates to treatment and monitoring. The important point to note is that only one, and any one, of the 28 criteria needs to be met for a patient to be considered appropriate for acute care. It is unnecessary to decide how many criteria each patient meets, and unnecessary to record which criteria are met. Once any single criteria has been met, you record this as a tick on the data sheet in the column for met criteria in acute care. Some criteria are much easier to meet than others, such as receiving intravenous therapy. These provide an easy, rapid way to assess patients as meeting the criteria.
Some patients will not meet any of the 28 criteria. This takes more time to decide, and it is recorded as a tick in the column for not met criteria for acute care. For information, the average proportion of patients not meeting criteria in the overall results of surveys so far is just over 20%.
We will now describe the additional information that needs to be recorded for all patients who have not met any of the 28 criteria for acute care.
Use the list in Chart 2 to assign the main reason why a patient not meeting the acute care criteria is still in hospital. The list of reasons is aligned to the National Delayed Discharge Codes with several additional reasons. It is only possible to choose one reason, and if more than one reason exists, please choose the most prominent or rate-limiting reason. Record the correct alphabetical letter on the data collection sheet in the Chart 2 column. If the reason does not appear on the list, choose option T for Other and make a note of the reason on the datasheet.
For all patients who have not met the acute care criteria, please select where the most appropriate area of care should be using Chart 3. The options are Home, Outpatient Follow-up, Non-Acute Area of Care and Other. If a patient was admitted from a nursing home and going back to a nursing home, this should be recorded as Home, but if it is a new placement, select Non-Acute Area of Care. Select Outpatient Follow-up for ambulatory care pathways such as DVT rather than simply routine clinic review.
To complete the data collection, record at the top of the sheet for each ward the names of the reviewers and a contact number. Record the ward name or number and the survey date. Confirm and record the total number of beds and the total number of patients surveyed. Record the number of any beds closed. Finally, record the number of boarders or outliers.
If the ward being surveyed is temporary additional capacity, unfunded capacity, or an area which does not normally have inpatients, such as a day procedure unit, record the number of beds as 0, even though patients are present and have been surveyed. The same applies if surveying patients in the emergency department who've been there for more than 4 hours. This will result in the patient total being greater than the bed total and will be picked up in analysis of the data.
Complete one line of data for each patient, starting with date of birth to enable calculation of age. Record the consultant's designated initials in the second column and date of admission to the hospital in the third column.
Decide if a patient is going to be discharged on the day of the survey. If discharge is definite, then tick the Discharge Today column. The only further data to be recorded on patients for discharge is whether or not they are a boarder. This should be recorded in the final column of the data collection sheet. Continue entering data for each patient using charts 1 to 3 as we described earlier. For all patients, complete the boarding details using chart 4 and the final column on the datasheet.
The remaining 2 columns on the datasheet are labelled Clinical Override. These can be used if the reviewers decide that the decision from Chart 1 is clinically incorrect. If the patient has met the criteria in Chart 1, but the reviewers consider that the patient does not require hospital treatment, the decision should be overridden by placing a tick in the column labelled Inappropriate. Don't forget to complete Charts 2 and 3 for these patients. Conversely, if a patient has not met the criteria, but the reviewers conclude that acute hospital treatment is still needed, the decision can be overridden by placing a tick in the column labelled Appropriate. There is no need to complete Charts 2 and 3 for these patients. In practice, the override is rarely used. The only important exception is for patients receiving rehabilitation in a designated rehabilitation bed that has been included in the acute hospital survey.
Such patients will either meet the criteria or have to be overridden as being appropriate if they do not meet the criteria. All data sheets should be returned to the central coordination point, where the data will be checked with you and then entered into the analysis. At least one member from each team should bring the data sheet to this central point. The reviewers have now completed the survey and can return to normal duties.
We hope that you found the survey interesting and that the results will be useful to your improvement programmes in the future.
And we'd like to thank you very much indeed for your interest in this survey.